A 62-year-old man, recently post-bone marrow transplant, presents with acute abdominal pain, severe fever, and profound neutropenia. I am showing you an abdominal CT on lung windows and soft tissue windows. Describe the findings.
Okay, looking at the images, the CT demonstrates marked asymmetric mural, thickening specifically localizing to the cecum and proximal ascending colon. There is extensive associated pericolonic inflammatory stranding and a moderate volume of fluid tracking into the adjacent ileocolic mesentery.
What critical diagnostic finding is present on the lung windows?
If we look closely, crucially, the lung windows reveal linear streaks of gas within the actual colonic wall itself, representing pneumatosis intestinalis. Importantly, the small bowel is entirely unaffected, and there is no frank pneumoperitoneum at this stage.
Given the patient's profound neutropenia and the severe right-sided colonic involvement, what is the primary diagnosis?
The primary diagnosis is severe neutropenic colitis, also commonly referred to as Typhlitis, complicated by acute bowel wall ischemia.
What is the exact pathophysiological mechanism that leads to this aggressive infection?
The profound neutropenia leads to a complete breakdown of normal mucosal integrity. This allows indigenous gut flora, primarily bacteria and opportunistic fungi, to aggressively invade the deep layers of the compromised bowel wall.
Why is the presence of pneumatosis in this specific clinical context a highly alarming sign?
In the setting of neutropenic colitis, pneumatosis indicates that the infection has progressed to transmural infarction. It is a dire sign of impending full-thickness necrosis and catastrophic bowel perforation.
How does the typical clinical presentation and anatomical distribution of pseudomembranous colitis differ from Typhlitis on CT?
Pseudomembranous colitis typically follows broad-spectrum antibiotic use and presents as a diffuse, extreme pancolitis involving the entire large bowel. Typhlitis specifically targets the cecum and right colon in severely neutropenic patients.
If this exact imaging appearance were seen in a patient shortly following a solid organ transplant rather than a bone marrow transplant, what opportunistic viral infection must be heavily considered?
In the post-solid organ transplant setting, cytomegalovirus, or CMV, colitis must be heavily considered as it classically presents with severe right-sided colonic inflammation, ischemic ulceration, and a high risk of perforation.
How would you manage this patient as a radiologist given the presence of pneumatosis?
This represents an acute surgical emergency. I would immediately place a critical results call to the intensive care and general surgery teams to report the impending bowel perforation.
What specific surgical intervention would you advise the team to prepare for?
I would advise the surgical team to prepare the patient for an emergent right hemicolectomy or a diverting ostomy. Medical management with antibiotics alone is almost universally fatal once transmural ischemia and pneumatosis have developed into Typhlitis.